So in this daily pathology, we'll be covering a few set of questions daily so that it will be easier for us to revise. And this is will be carried on in other two subjects as well. So moving on. So these are the contents that will be discussed for today. That is necrosis, Barrett's esophagus, basal cell carcinoma, Hodgkins disease, Phyllodes tumor, and Leukemoid reaction. So these are 6 random questions throughout the subject, and let's start. So firstly, there's necrosis. Necrosis is basically death of a tissue and also degradation of tissue by hydrolytic enzymes that is mainly released by the dead cells. And there are a lot of factors which can lead to necrosis, such as physical and chemical agents, can be through microbial agents, can be through immunological injury, and also hypoxia. So based on the morphological features, it is divided into 5 types that is mentioned in this slide. That is coagulative necrosis, liquefaction necrosis, which is also known as colliquative necrosis, then caseous necrosis, fat necrosis, and fibrinoid necrosis. Now I'll be dealing everything individually. That is coagulative necrosis. Coagulative necrosis is the most common type of necrosis. It is mainly caused due to a cessation of blood flow, and the main organs that it affects are heart, kidney, and spleen. So when you see grossly, the early stage is known as infarct, where it appears pale, and later it moves on to a more yellowish and shrunken form. And when you see it microscopically, it appears as tombstone structures. That is nothing but it has an outline, whereas the nuclear and cytoplasmic material are totally lost. And the characteristic findings you see is pycnosis, karyohexis, and karyolysis. Then moving on to the liquefaction, or also known as colliquative necrosis. In this, it is mainly due to ischemic injury, and it can also take place due to bacterial or fungal infections. And whereas in the previous necrosis, that is coagulative necrosis, there is not much involvement of the bacteria and chemical agents. And moving on, the examples of liquefaction necrosis is infarct brain and abscess cavity. And when you look at it microscopically, there's something called cystic space, and this contains macrophages, which contains mainly the phagocytosed material and also the necrotic debris. And in case of the brain, the cyst wall is formed by proliferating capillaries, inflammatory cells, and gliosis. And in case of abscess cavity, it is formed by proliferating fibroblast. Then moving on to the third category, that is caseous necrosis. So caseous necrosis comes from the word caseous, that is, it is nothing but cheese-like. So it appears as dry cheese, which appears in yellowish also. And it is believed that this color is due to presence of liposaccharides. And talking about it microscopically, it has a scattered debris of nuclei, and there's also granulomatous inflammation reaction which is seen, and it consists of mainly the cells, that is epithelioid cells, Langerhans cells, and also the lymphocyte. Then moving on to the fat necrosis. Fat necrosis, as the name suggests, it affects only the adipocytes, and examples are traumatic fat necrosis of breast and the mesenteric fat necrosis of during acute pancreatitis. So talking about what happens in acute pancreatitis is there's a release of pancreatic lipase, and in fat necrosis there's hydrolysis and rupture of adipocytes as mentioned earlier, and here the neutral fat, it's converted into two products, that is glycerol and free fatty acids, and it combines with calcium and undergoes a process known as saponification. So grossly, when you look at fat necrosis, it appears yellowish white, and it also appears as chalky white appearance in presence of along with calcium soaps. Then moving on microscopically, the necrosed fat cells, it has a cloudy appearance, and the calcium soaps, it is identified as amorphous, granular and basophilic material. So then moving ahead with fibrinoid necrosis. Fibrinoid necrosis is characterized by a similar deposition of fibrin-like material, and this has staining properties similar to that of PTAH stain, that's nothing but tungstic acid hematoxylin. And the examples here are arterioles in case of hypertension, peptic ulcer, autoimmune diseases, and immune complex vasculitis. And microscopically, it is identified as a brightly eosinophilic material, and it has hyaline-like deposition in the vessel wall. And the local hemorrhage also may be present due to the rupture of vessel wall. Moving ahead, we'll be looking at the second topic, that is Barrett's esophagus. So Barrett's esophagus is nothing but after reflex esophagitis, the stratified squamous epithelium of the lower esophagus, it gets changed or it's replaced by the columnar epithelium, and this condition is nothing but Barrett's esophagus. So here what happens is this Barrett's esophagus, the Barrett's epithelium, which is nothing but the columnar metaplasia. So there what happens is it progresses to dysplasia, and also it can progress to esophageal adenocarcinoma. So going about the morphological features, that is it appears red and velvety, and at the squamocolumnar junction there's presence of hiatus hernia and also peptic ulcer, and microscopically you can see the presence of globulate cells and also Paneth cells, and there is intestinal metaplasia that can be seen along with dysplasia, and there's presence of peptic ulcer also due to the presence of fundic gastric glands and also cardiac mucus glands, and it is also accompanied by inflammatory changes, and it can lead to the development of stricture also. And the diagnosis that is recommended is endoscopic biopsies can also be used to study the illness. Moving ahead, we'll be looking at basal cell carcinoma. So basal cell carcinoma is nothing but a locally invasive slow growing tumor which is mainly found in the middle age, and it is found mainly on hairy skin, and the most common location is the face, and there is an imaginary line which can be drawn from the lobe of the ear to the corner of the mouth, and in this region it is very common. And talking about where it is most commonly found, it is most commonly believed to be found in light skinned people with a little melanin, and also in strong exposed sunlight areas, and also in case of inherited defect in DNA, that is in the xeroderma pigmentosum. And there is another syndrome which is related, that is nevoid basal cell carcinoma syndrome, which is nothing but presence of multiple basal cell carcinomas, and this is found mainly in young age. And here it's believed that it is a defect of two alleles. One defective allele is present in the PTCH gene on chromosome 9, and the other allele, it undergoes a mutation due to early exposure of sunlight. Then moving on to the morphological features, it undergoes central ulcerations and the margins it is rolled up, and this pattern is similar to that of a tissue which is attacked by a rodent. So that's how the name, it is also known as rodent ulcer. So moving ahead, histologically, its characteristic feature is nothing but proliferation of basaloid cells. And talking about basal cell carcinoma, there are a variety of patterns of cells that can be seen. That is solid masses, there is present masses of pigmented cells, there is masses of tumor cells, keratotic masses, cystic change with sebaceous differentiation, and also adenoid pattern with apocrine and ecrine differentiation. But the most common pattern that can be seen is solid basal cell carcinoma, which has basaloid cells with irregular masses, and also it has peripheral palisaded appearance of the nuclei. Moving on to the next topic, there is Hodgkins disease. So Hodgkins disease is mainly involving the lymph node, and secondarily it can also affect the extranodal sites. And this disease can be seen in two peaks, that is one in young adults and also in older individuals. And Hodgkins disease is mainly present in young adults than in females, and the most diagnostic feature is presence of RS cell, that is Reed-Steinberg cell or Dorothy Reed-Steinberg cell. And another diagnostic feature that can be done is through biopsy. And moving on to classification, there are two classifications. One is by WHO and other by Reich classification. And Reich classification is adopted since 1966. And talking about Reich classification, it is divided into lymphocyte predominance type, nodular sclerosis type, mixed cellularity type, and lymphocyte depletion type. And talking about WHO classification, there's a new type known as nodular lymphocyte predominant Hodgkins disease, and second type is classical Hodgkins disease. So the main diagnosis, as mentioned earlier, is to find the presence of Reed-Steinberg cells. But Reed-Steinberg cell can also occur in cases of infectious mononucleosis and also in other lymphomas. So only the identification of RS cannot be the only criteria for confirmation of Hodgkin's disease. So moving on, the types of RS cells, that is Reed-Steinberg cell. There is classic RS cell, lacunar type, polyploid type, and pleomorphic type. So under classical RS type, it is a large cell. It has a bilobe nucleus, which often appears as mirror image, and it can be multilobed. And the nucleus is mainly eosinophilic, and the nucleolus contains a clear halo, which gives an owl eye appearance. And the cytoplasm, when considered, is abundant and amphiphilic. So classical RS cells, the thing you need to remember is it has owl eye appearance and cytoplasm is abundant, and bilobe nucleus with mirror image. And going on to lacunar type, it is smaller and it has a lacuna, as the name suggests, lacuna or a pericellular space, and this is formed due to shrinkage of the cell cytoplasm, and this lacunar type is a feature of the nodular sclerosis variety of the Hodgkins disease. Next, moving on to the polyploid type, which is also known as the popcorn type because it appears in the shape of a popcorn. It is mainly seen in lymphocyte predominance type of Hodgkin's disease. Moving on to the pleomorphic RS cells, they are the features of the lymphocyte depletion type. So they have the pleomorphic as well as atypical nuclei. Then moving on, one important thing is that the RS cell in lymphocyte predominance type are negative for both CD15 and CD30 but are positive for the CD20. Then moving on to the morphological features, the Hodgkin's lymphoma mainly affects the cervical, supraclavicular and the axillary groups, and here the infiltration of the surrounding tissues can also be seen. And in case of a sectioned surface, the lymph node, it appears grey white and fish flesh like, and nodular sclerosing type of Hodgkin's disease, they can show mixed cellularity, and also the lymphocyte depletion types Hodgkin's disease may show abundance of the necrosis. So moving on to the classification of WHO, that is classic Hodgkin's disease. Under lymphocyte predominance type, there is proliferation of small lymphocytes along with varying number of histocytes forming nodular or diffuse pattern. Under nodular form, there is large neoplastic nodules. Under diffuse form, there is diffuse proliferation of cells. Then moving on, for the diagnosis of RS cells, there is also presence of polyploid variant having polyploid and twisted nucleus. This is seen in some cases, and this type of Hodgkin's disease does not show cells like plasma cells, eosinophils, neutrophils, and also necrosis and fibrosis are not seen. Nodular sclerosis type, this is the frequent type of Hodgkin's disease, and here this is more common in women than in men. And the characteristic feature under microscopy is bands of collagen that is present, and occasionally the entire lymph node may be replaced by this hyalinized collagen. And talking about lacunar type, and other feature is lacunar type RS cells. It has a distinctive halo which is present, and as mentioned earlier, this is due to the presence of shrinkage of cytoplasm. And in case of Zenker fluid, the use of Zenker fluid, the pericellular halo is not seen. And there are other features that are seen, that is the nodules between the fibrous septa consist mainly of lymphocytes and macrophages, and can also present with necrosis. Moving on to the mixed cellularity type. So here the entire lymph node is replaced by heterogeneous mixture of normal cells, and they include lymphocytes, histiocytes, eosinophils, neutrophils, and the plasma cells. Some amount of fibrosis and necrosis can also be present here, and typical RS cells is mainly found in the mixed cellularity type. Then moving on to the lymphocyte type. Under lymphocyte type, the lymph node is depleted by lymphocytes, and there are two variants, that is diffuse fibrotic variant and also the reticular variant. Under the reticular variant, it is more cellular, and there are large number of atypical pleomorphic histiocytes, scanty lymphocytes, and also few RS cells, typical RS cells. Under diffuse fibrotic variants, it is hypocellular, and the entire lymph node is replaced by fibrosis, as the name suggests, and it appears as homogeneous and fibrillar hyaline material. And the area of hyalinosis, it contains lymphocytes, atypical histiocytes, and also typical and atypical RS cells. Then moving on to the second category in WHO, that is nodular lymphocyte predominant Hodgkins disease. It was actually previously included in the lymphocyte predominant type of Hodgkins disease. So talking about the features, it has nodular growth pattern, and just like the lymphocyte predominant pattern of classic type, there is presence of small lymphocytes along with sparse number of RS cells. So here there is CD45 positive, EMA positive, that is epithelial membrane antigen, and it is negative for CD15 and CD30. And here the it has a chronic relapsing course, but it can also transform to B cell NHL, that is non-Hodgkin's lymphoma, in some cases. And coming to the most important part of Hodgkin's disease is finding the clinical features, knowing the clinical features. So here the patient, he mainly presents with painless movable lymphadenopathy, and mainly involved regions, as told earlier, it is cervical, mediastinal lymph nodes mainly involved, and they can also present with enlarged spleen, that is splenomegaly, and constitutional symptoms can be present such as low grade fever and also night sweats and weight loss. Other symptoms such as fatigue, malaise, weakness and pleuritis may also be seen. So talking about lab findings, how do we diagnose, how do we find out Hodgkin's disease? Here firstly we need to know the hematological abnormalities should be seen. That is mainly moderate normocytic normochromic anemia is present, and the TIBC and the serum iron is usually low, but the marrow iron stores are mainly normal, and marrow infiltration by the disease, it can produce marrow failure with leukoerythroblastic reaction. Moving ahead, it can also we can also use routine blood counts for checking leukemoid reaction. And in case of pleuritis, peripheral eosinophilia can also be seen. And in case of advanced disease, there is absolute lymphopenia. And talking about the platelet count, it can be increased, and ESR is also invariably elevated. And looking at the immunologic abnormalities, there is fall in the immunocompetent T cells with defective cellular immunity. There is a reversal of the CD4 to CD8 ratio, and there is energy to the routine skin test. And the humoral antibody production is normal. Talking about the classification, this is also an important aspect of the Hodgkin's disease. There is Ann Arbor classification of Hodgkin's disease. So it is divided into, there are few keywords which need to be known. That is A. A refers to the presence of constitutional symptoms, that is nothing but fever, night sweats and unexplained weight loss. And B is nothing but absence of these symptoms, that is fever, night sweats and unexplained weight loss. And the use of the code E is used for extranodal involvement, and S is for splenomegaly. I repeat, S is for splenomegaly and E is for extranodal involvement. So moving on to the stages, there is stage 1, that is nothing but just stage 1. Under that there is stage 1 and stage 1E. So under 1 there is involvement of single lymph node region. Under 1E there is involvement of extranodal site, as mentioned E is for extranodal region. And stage 2, in 2 there is involvement of 2 or more lymph nodes, and this is on the same side of the diaphragm. And 2E, there is involvement of the extranodal organ or site. And stage 3, there is involvement of the lymph node on both sides of the diaphragm. And stage 3E, there is extranodal involvement. And 3S, involvement of the spleen. And there is also something known as stage 3ES, which is nothing but involvement of extranodal site as well as the spleen. Moving on to the stage 4, there is multiple or disseminated involvement of one or more extra lymphatic organs or tissue, which may be present with or without the lymphatic involvement. And moving on to the main diagnostic studies, a detailed physical examination is recommended for checking the nodal involvement and also the splenomegaly, and also chest radiograph can be taken to exclude the mediastinal, pleural or lung parenchymal involvement, and also CT scan of abdominal and also pelvis can be seen, and documentation of constitutional symptoms can be seen, and CBC, liver and kidney function tests can be seen, and also bilateral bone marrow biopsy, and mainly the histopathological study. Moving on to the prognosis, the lymphocyte depletion type is the most aggressive form of the disease, and the nodular sclerosis, it has a very good prognosis, but in presence of large mediastinal masses, it can respond poorly to the chemotherapy and radiotherapy, that needs to be known. And the mixed cellular type, it basically forms the intermediate between the lymphocyte predominance and also the lymphocyte depletion type. And the lymphocyte predominance type, that also has a very excellent prognosis. Then just summarizing the few key points of Hodgkin's disease. The Hodgkin's disease is mainly involving the lymph nodes. Sometimes it can affect the extranodal sites as well. And under microscopy, it is classified into classic and nodular lymphocyte predominance type. And under classic there are a lot of variety, that is lymphocyte predominance, nodular sclerosis, mixed cellularity, lymphocyte depletion type. And here the lymphocyte predominance Here the nodular sclerosis is the most common type and the lymphocyte depletion type is the least common type. And the prognosis of lymphocyte predominance Hodgkins disease is the best. And as mentioned, the lymphocyte depletion type has the worst prognosis. And the staging classification is mainly done by and above staging. And it can be diagnosed by biopsy as well as characteristic RS cell presence. Moving on to the next topic, that is Phyllodes tumor. Phyllodes tumor was formerly called cystosarcoma phyllodes. It is nothing but an uncommon bulky breast tumor, and on gross appearance it appears leaf-like. It resembles fibroadenoma, similar to that, and Phyllodes tumor can be classified into three categories, that is benign, borderline or malignant, depending on the feature of the stromal cells. Talking about the morphology, they are large, about more than 10 cm in diameter, and they are less encapsulated compared to the fibroadenoma. And on cut surface they can appear grey-white along with cystic cavities, and they also contains areas of hemorrhages, necrosis and degenerative changes. On histology, there is hypercellular stroma that is seen, and also benign ductal structures that are seen. And the three types of Phyllodes tumor, that is benign, borderline, malignant, are divided keeping into consideration of these factors, that is frequency of mitosis, cellular atypia, cellularity and infiltration margins. And these Phyllodes tumors, they can be malignant, and also they can have the property to metastasize. Next, we have Leukemoid reaction. So this is a very interesting topic. So here there is reactive excessive leukocytosis that is present, and it is similar to that of leukemia, but here the clinical features such as splenomegaly, lymphadenopathy and also the hemorrhages, they are usually absent. And coming to classification, it is classified into two types, that is myeloid leukemoid reaction and also the lymphoid leukemoid reaction. So talking about the myeloid leukemoid reaction, it is majority of the cases comes under the myeloid leukemoid reaction. And talking about the causes, it may be due to infections, intoxication, malignant diseases, and also in cases of severe hemorrhage and severe hemolysis. So talking about infections, it may be due to staphylococcal pneumonia, disseminated tuberculosis, meningitis, diphtheria, sepsis, endocarditis. Intoxication may be due to mercury poisoning, severe burns, eclampsia, and malignant diseases such as multiple myeloma, Hodgkins disease, bone metastasis, myelofibrosis. And coming to the laboratory findings of the myeloid leukemoid reaction, there is leukocytosis, usually moderate, and there's presence of metamyelocytes, myelocytes, myeloblasts, and infective cases can also show toxic granulation and Dole bodies, in the cytoplasm of neutrophils, and here the NAP or the LAP, that is neutrophil alkaline phosphatase, and also the leukocyte alkaline phosphatase are usually higher, and this can be used to distinguish between the CML, that is chronic myeloid leukemia, with the leukemoid reaction. And it also has a negative Philadelphia chromosome that can be used to distinguish between the CML. Philadelphia chromosome is nothing but the BCR-ABL fusion gene. Then moving on, additional features like anemia, myeloid hyperplasia of the bone marrow, and there is absence of infiltration by immature cells in organs and tissues. Then moving on to the lymphoid leukemoid reaction. Causes is similar, that is infections, and in case of malignant diseases, infections, that is infections due to cytomegalovirus, pertussis, chickenpox, measles, tuberculosis. And just to summarize the leukemoid reaction, it is nothing but proliferation of leukocytes, which is mainly it can be myeloid or lymphoid. Myeloid is more common type, and it requires it is from CML, it is distinguished in presence of having a higher LAP or NAP score, and also the Philadelphia chromosome, it turns out to be negative. So next, that's it. Thank you. So I will be making videos of similar fashion daily, so that it will be easier for the revision process. And these topics are not necessarily from a single chapter, it can be across various chapters, so that it helps us to get a broad view of what we are studying. Thank you.